So we appreciate everyone being here as everyone's getting settled in. Today's topic, as you can see on your screen, is patient safety and event reporting. And if you all, where are my PGY 2s, 3s, and 4s, right? You've seen on the surveys, right? Have you had an opportunity to participate in safety, event, investigation, and analysis? And have you? Well, one basic way is M&M, right? If you participate in any M&M conference, you've done it, right? If you participate in this grad round, you have done it, right? But you do that every day in your rotations and throughout your program. So if you ever see that question again, which hint you will in the spring when the annual survey comes out about event safety, event investigation and analysis, you know the link, right? Today, we are fortunate enough to have representatives from both of our major affiliates, our major partners and training sites. So as you can see on the screen, we have Garcia from your very own Valley-Wise Health right here. And we have Angela Miranda from St. Joseph's Hospital and Medical Center as well. And so on that note, I'm going to turn it over to Crystal Garcia to kick off our grad round. Thank you.
Okay, so welcome everybody. So good afternoon. And again, I'm Crystal Garcia. I'm the Vice President of Specialty Services, Quality, and Patient Safety here at Valley-Wise. And so that entails covering our regulatory department that we have, patient safety program managers, infection control, and quality analysts. So we all are in one department together. And so then I wanted to go over a couple of our learning objectives that Angie and I are going to be reviewing today. And again, at the end, we'll welcome questions that hopefully that we'll be able to answer. And if we don't know the answer, I'm sure her and I will do research and get the answer to you guys. So first up is just our learning objectives. Again, we want to make sure everyone understands patient safety event reporting and the analysis that goes along with that. Again, investigation, the process of our patient safety events, root cause analysis. It's a very important process that we do here at Valley-Wise, and I know St. Joe's, they also have a process they utilize. Again, we also participants to be able to understand the level of severity assigned to an event and even if the deviation occurred. And then understand the importance of entering the IRIS, which is what the system that's utilized over at St. Joe's for event reporting. And then here at Valley-Wise, we call it Check It. It's also MIDAS. If you ever hear, it's kind of one and the same. You'll hear some people reference it as MIDAS, others reference it as placing a Check It. So, but it is the same thing. On the next slide. So again, just want to start, why is it important to do our patient safety event reporting? And the reason it's just essential for helping to reduce errors, also to develop corrective action. So when we look at the data analysis of the events that get input into the system, we're able to track and trend that data, determine what is important that needs to have some process improvements that need to be implemented, and so that's those corrective actions. Also, we can learn again from these events that get entered into the systems that we utilize. The lessons learned is very important. We can't stress enough. If we don't know about it, it's not entered into the system to be able to see it and be visible. So again, it's very important to get these entered. Again, also it helps create, we want everyone to be aware and to know it's non-punitive. There's a non-punitive culture that we are creating. We have a large emphasis on that, especially in the past year here at Valley-Wise, that, the importance of entering that information is important to see. We expect people to enter, and that there will be no punitive issues for that reporting. It just also cultivates, a supportive culture for people to do this. On the next. A couple, like for the event, patient safety event reporting, we see barriers and we understand there's barriers out there. Some of the strategies that we're doing here at Valley-Wise Again, one of the barriers we know that people face is people believe it don't contribute to improvement. Again, they don't feel like they see the communication back to the staff of the changes and improvements that happen. But here at Valleywise, we have a lot of various committees. We have a inpatient care and safety committee. We have a medication safety committee. There's various committees that we have throughout the organization, and we actually welcome if any of you guys or any of the residents you know want to be on those committees to help bring feedback and to hear what's happening. Please reach out to me. We welcome you to send that invite to you to be able to join those. We do a lot with our information through a newsletter. We also do employee forums to get information out there. So there's a lot of, we provide that feedback on what we're seeing from all of these events that do get reported. Another one that we see is reluctance they feel the reluctance to tell on another healthcare worker, like they're tattletelling, but that's not how we see it. Again, we want people to know it's not punished for entering the errors. Is to help establish a just and fair approach to evaluating everything that gets entered. It helps us, look at the 5 whys. Why did this happen? To work through that process. Also, another one is just a lack of involvement of physician providers in the event reporting system. And so kind of the strategy we're working is to get feedback on our system. Again, we say here we use what we call Check It or Midas. So we want the feedback on how that system works. One of the things we've heard in the past is, it is kind of, we use Epic as our EMR, then you have to go into the other system to do the event reporting. So we are in the beginning stages of actually adding a link into Epic to where you would click the link and it would take you right to the patient safety event reporting system. And there will be pre-populated information and, for the patient, a lot of the demographics. So that is in the works, and we hope to have that up and running in the next several months. So we're looking forward to that. I don't think it's on. There we go. Sorry. To the next slide. And on the next few slides is just to show, the system we use, again, Check It, and as well as you see Midas, on where to enter the patient safety event. And so on this slide, on the Vine that you guys, the internet that we utilize here, you'll see underneath the app section. And then when you click on that, then it says Check It, patient safety event reporting, and that's where you begin entering the information. And then on to the next slide. This just shows when you're in the system, there's some, if it's bolded, that is the required fields, and those, you have to enter or you won't be able to move forward. So it's important that you finish, can do the bolded fields that we have, so then this can be recorded. And then the next slide. Just want to point out, it is very important to save your work. Make sure you hit that save button up in the corner because then it will be entered. There's also a time limit that's at the very bottom left corner in Midas. And it gives you time and it counts down. So you also want to pay attention to that, because if it times out, then your work will not be saved. So on to the next slide. This is where I just wanted to go over some of the examples that we have to show that we do utilize the data that's entered into our system in regards to data analysis and for patient safety. As I had said, we have various committees, and we do, again, can't stress enough, we'd welcome you guys onto those and to get that feedback from you. But here's an example of hospital-acquired pressure injuries. We look at this, we get entered into the system, and then we're able to pull the data, and we're able to look to see where we're having our issues, which months, which stage of pressure injuries, and then again, a work group comes together. They look at this data, they look at cases, they'll do chart reviews, and then they've met some of the changes that they've made recently is reviewing all of our products, sorry, all of our products that we utilize, again, implementing education for staff. And those are just a couple of the examples that they've done based upon the data that's entered into to check it. The next slide that we have here, again, is medication errors. We know that medication errors are one of the most common ones that are out there that we see. Again, can be preventable. And this kind of leads into like one of the reasons we would do a root cause analysis is, medication errors. And so with the root cause analysis, you can look at a lot of times there's usually a lack of standardized procedures for the medication administration. And then you're able to implement like new standardized protocols or the double checks that are required for that. And then the next couple of slides, it kind of leads also into medication medication errors is one of your most common that we see. We do gather a lot of data out of MIDAS for medications. There, again, a medication safety committee that meets to review this on a monthly basis. And you can see administering is one of the higher ones that we see errors occur. And then the next slide, again, incorrect dose is one of our highest, and incorrect time are usually our highest ones that we see, and that group works on based upon the data and to implement changes. And then the next is just the investigation process of patient safety events. And again, we call root cause analysis is what we call these investigations. And again, these investigations that happen, they result in a patient that had harm or undesired clinical outcomes. Again, in these root cause analysis that get done based on a patient safety event, identify strategies to help reduce medical errors or improve patient safety. The one thing I have highlighted here, just the clinical participation in these root cause analysis is very vital. It's very important that we hear everyone's view on the processes when we are doing root cause analysis. It's not placing blame on anyone. From a patient safety perspective, we are trying to figure out where the process broke down and where we can make improvements so it don't happen again within the organization. On the next slide is just, again, broke down some of the common categories where you will see root cause analysis being done: surgical errors, diagnostic errors, and medication errors. So these were just some of the highlights. Those are the ones usually that we see with root cause analysis. On the next slide, again, when we do a root cause analysis, again, an event has occurred, we begin the investigation usually pretty much right away. There's a lot of just initial gathering of information. So we start that investigation. We have patient safety program managers here that will begin looking at the chart. Then they'll see who all was involved. Then they'll reach out to those individuals to schedule interviews. And again, that goes back to the importance of having clinical staff involved in participating in those interviews. Again, gathering the data and then analyzing the data of what they found, reviewing the chart, what they saw in there. And then once a group comes together here at Valleywise, when we have in-person root cause analysis, we usually do them on Thursday mornings. And then we get a group together, you come into a room, several individuals, and it's just to review what happened. And again, we're focusing on processes, not putting blame on anyone, just the processes of what happened and where those processes failed. And during that action or that root cause analysis, action plans or, corrective actions are developed on processes that we need to implement and put in place so that it don't occur again. And then at the very end, you complete that. And the big important step to this is the follow-up, making sure those corrective action plans were implemented and they're working. And so that's very important because you can implement something and then it might not have been the correct thing to do. So you always go back and do that follow-up. And on the next couple of slides, these are just a couple of cases just to give examples of when you would potentially do a root cause analysis. This one is talked in regards to a 42-year-old man had end-stage renal disease. He was getting a donor kidney. Again, at the end of the case, they were to give 3,000 units of intravenous heparin, but instead they ended up giving 30,000 units of heparin. So the persistent bleeding continued, and then they had to had irreversible damage, and they had to remove the transplanted kidney. And the gentleman continued back on end stage on hemodialysis. So with this, we would look at it. We would interview all the staff that were involved, determine how did the medication error occur, what kind of processes could we put in place so it don't happen again. On the next slide, just another example. Again, I had with medications prior to the start of the procedure, 2 doses of the neuromuscular blocker instead of 1 dose was given. And again, the patient, as they were getting transported to the OR, began having trouble breathing and unresponsive. She was intubated and given oxygen and did okay. She began breathing, then was extubated at the end and went back to PACU. But again, in this, we would look at the anesthesia providers, the pre-op nurse, anyone else that was involved during this, and get their feedback, get them in a room, do the interviews, and to determine individual processes that need to be corrected so this would not occur again. So with that, again, I can't stress enough the importance of having individuals report. We do welcome, we highly encourage the reporting, and check it is anonymous. You can do it anonymous. We encourage you to put your name as well. So then if we need to do follow-up, we can do that. But again, it's just important to get that feedback to be able to make these improvements and do the data analysis on our patient safety events. Thank you. Then here's Angie.
I talk kind of loud, so I might have to back this up a little bit. You guys can still hear me. All right, I'm Angie Miranda. I'm quality risk manager, patient safety over at St. Joe's and St. Joe's Westgate and the rest of the entities there. We share a sentiment to Valleywise in patient safety reporting and the importance of it, and making sure that you guys understand it's non-punitive and we use it to improve our patient safety processes. Over at St. Joe's and St. Joe's Westgate, we utilize a platform called Origami Risk. And within Origami Risk platform, there's this IRIS reporter. It stands for Incident Reporting Information System. This icon is on every single PC throughout the hospital, and it's also on those mobile computers that are around the hospital everywhere. So you can get on it either any of those 2 places. It's broken down into different categories: patient care events, visitors, employee injuries. So if you're an employee, you have an injury, you would put it in there. If they have a visitor injury, they would put it in there. We focus more on the patient care events. Every one of those little blocks has a subcategory to it. So let's say, for instance, under patient falls, we may have accidental, anticipated, unanticipated physiological falls, and then under medications, it may be like an omission or the incorrect dosing of a medication. So those would go into those areas. All right, types of events that are reported. These are a category of different types of events that are reported. I pulled January 2023 to January 2024 for our data, and we reviewed 11,392 events for that year period. And you'll see behavioral is usually one of our top ones. That's because within there, it's not even patient behaviors or anything. It's also AMAs, like without being seen, and elopements are categorized underneath there. So that's usually why behaviorals are our biggest one. General patient care is our next one that is our biggest category, but all staff, clinical, non-clinical, students, residents, everyone, we encourage everyone to put in event reports because those really help with our patient safety. So we look here and like, how are they categorized? So we use at Dignity Health, we use NCC MERP for our categorizing our severity level. You can see it starts at 9, and that's the white area, all the way down to the dark red, which is patient death, which is an I9. So an A1 circumstances or an event that has the capacity to cause harm, but there was no harm associated with that. When you get down to the like the pinkish and whitish areas, those are when you get into the patient harm. So our temporary harm for a patient requiring an intervention, let's say it's a high fall risk patient, falls out of bed, gets a scrape on his leg, we have to clean it, put a dressing on, that would be a 5. Temporary harm, the patient requiring initial or prolonged hospitalization, patient falls out of bed, gets a scrape on his leg, also ends up with a head bleed that or a big old hematoma on their head, you know, and we have to hold the discharge, get CTs, those kind of things. A G7 permanent harm, let's say the patient fell and we ended up with a head bleed, and then H8 interventions required to sustain life. Let's see that head bleed, had to go to the OR and be evacuated or something. And then patient death. So if the patient ended up going to the OR, ended up dying in the OR, then that's the category it would go into. Next slide. Then we look at deviation. What are the deviations? So did a potential or actual either temporary or permanent harm occur as a result of patient care and not the disease process? So let's say, for instance, a patient comes in the ER with chest pain and they go to call the cath lab and we have the wrong cath lab schedule. So that would be patient care, not the disease process. It's not the patient's chest pain that's causing the error. And then we look at, was there a deviation in the general accepted performance or those gaps? So yes or no. Did we get the wrong call schedule and it was sent out, but nobody ended up receiving it? And then did the deviation reach the patient? So let's say we got the call schedule, we were able to figure it out right away. We were able to get the cath lab to come in. There was no harm to the patient. They got to the cath lab at the appropriate time. That would end up being the near miss event area, the yellows, the A's and the B's. And let's say it did end up going, did the deviation cause moderate to severe harm? That's either a yes or a no. So patient got to the cath lab, ended up getting a couple of stents, went to ICU for the night, discharged home. No bad outcomes came of that patient. That would be your C3s and your 5s. But let's say that they did end up having moderate to severe harm, got to the cath lab, there was a delay, patient ended up passing away or something in the cath lab, then that would go into our F6s and aboves, and those are our serious safety events. Next slide. Here's using those events that we had. This is the kind of breakdown A1 to I9. You'll see our biggest ones are A1 through D4s or the nuns. And then our highest focus ones are our 5s and above. So all events that come through are reviewed by a patient safety officer. The E5s with deviation, we review as a group every single week to confirm that severity level. Sometimes it needs to go up in severity, sometimes we bring it down in severity, but we always look at every single E5s as a team. An F6 or above, with or without deviation, are reviewed by the team, but they're also reviewed by executive leadership to confirm that severity level. And then an F6 or above with a known deviation, those are serious safety events. Those are debriefed within 24 to 48 hours of the event happening. We include the floor staff, the managers, the supervisors, the physicians. Let's say it was the cardiology area. We would have the cardiologist, or if the patient was up on the floor and had chest pain and we had a delay, it would be the cardiologist and that med staff team. So we would want everyone included in there in the review of the event. Then we go into our event investigation and analysis. This is the same as the RCA process. We just call it something a little bit different. But it's the same thing. It's a robust review. We look at causations, we put together action plans, and then we continue to assess those action plans and have an actual tangible effect to it. And we review those every 36 days. If it doesn't become a common practice at that time, then we would extend that on. All right, here's a case study involving a resident. We're going to say this resident's name is Dr. Sharabi, but every single one of our case studies that I present, we have alias names, so it's actually my dog's name. So we're going to say Dr. Sharabi put in this event, and it was upon assessment, they identified that the patient had increased shortness of breath and crackles in bilateral lungs. Furosemide 40 milligrams was ordered IV ×1 stat. It was ordered at 13:10. At 14:22, they called a rapid response for respiratory distress, associated tachycardia. Upon arrival, the patient required intubation and transfer to ICU for a higher level of care. Now, when we put in event report, we want to know what was the details of the event, but then also what were the immediate actions that were taken. So they looked at the event, realized that the furosemide was not given, they administered it right away, and the patient ended up putting out 1,100 cc's. The next slide. Now this is where I'm going to have you guys get a little bit more interactive with me. So I'm going to have you help me decide whether or not there was deviation or no deviation in this. So did a potential or actual injury, either temporary or permanent, occur as a result to the patient care and not the disease process? Yes or no?
So yes.
Yes. Okay. Was there a deviation or in a generally accepted performance in our gaps? Was there a deviation in there? If our standard is to give the medication stat, what would it be, a yes or a no in the care process? Yes.
Yeah.
Okay. Did the deviation reach the patient?
Yes.
And did the deviation cause moderate to severe harm or death?
Yes.
Yes. All right. Let's go ahead and go to the next slide. Now, can you guys help me determine what is the severity level that you would classify this event in?
6.
Well, it was temporary harm and it required initial or prolonged, but what else could we have chosen in there? At 8, yeah, the patient ended up having to be intubated and went to the ICU. So that would be considered an intervention required to sustain life. So that would be an H8, and we would definitely review this one in an EIA process. We would review it with a smaller group within 24 to 48 hours of the event happening, because everything is it stays in your mind a lot clearer the faster that we get it done. And then we'll set up a big, more progressive EIA process. All right. So then we
Can you
look
go
at
back,
what-
sorry, can you go back one slide? Can you share what patient safety work product privilege is for everyone?
So patient safety work product privilege, when we do an EIA process or we provide any patient information, that means that stays within that. We want interaction, we want people to be honest and open, and it's a safe space for you guys to provide us information. Sometimes it gets a little bit heated, but we try to be very respectful, and we want to make sure that everybody has an opportunity to give us the information that they need, even if it may hurt the feelings of another person. But it's important that we end up getting all of that information. It stays within that group. It does not filter out throughout the hospital. So there's no punitive actions in any of these. We do put that on there as an attestation that you understand that anything that is shared in that group for that review stays within that group. Thank you. So we look at what did the investigation reveal? We try to break down each one of those things. So unfortunately, this poor nurse had to leave abruptly due to her premature rupture of membranes. So she gave a very brief report to Tiki, another one of my dogs, and that Tiki was the charge nurse, and he divided up all of the patients throughout the that person was leaving with, and was divvying them up to all the other nurses on the floor. But Tiki did not provide an assessment on these patients. So very brief report. It wasn't like a bedside handoff where we do an SBAR process on handing over our patients. It was very brief. So he wasn't really sure of the acuity level of these patients. So, he didn't go in and assess those patients to decide, am I going to be divvying them up fairly? And then Havana, the nurse that was going to be getting the patient, yes, a third dog of mine, was in another room with one of her patients who had just gotten back from EGD and was having an acute bleed. So her focus at that time was helping get that patient stabilized and back on to endoscopy. But Havana did not end up communicating with Tiki that her patient was having a bleed. Had she done that, maybe he could have gone in there and helped her, or I better not give her another patient at this time because she's very preoccupied. So by the time Havana ended up getting into the room, her patient was in acute respiratory distress. She immediately called an RRT, not knowing a whole lot about this patient either. So it made that part of it a little bit more difficult. And then we also revealed Dr. Sarabi, she didn't tell staff members that the patient was short of breath, and she didn't let anybody know that she had a stat order in. There's charge nurse phone numbers on every whiteboard in the room. All those, the patients have phones in the room, they can call them. Could put on a call light. Every patient has a call light. Hey, can we get somebody in here? And then actually when she got done, she went and sat down at the nurse's station. She was sitting right next to Tiki, the charge nurse, and they were talking about the individual who had to leave because of her rupture of membranes, but we didn't end up discussing, they have a patient short of breath, and I put in a stat order. So you look at those things as improvement measures, process improvement measures. It's usually 99% of the time comes down to communication. So we have a huge emphasis on communication with our staff. And then we look at putting in action plans into place so that it doesn't. Then why is it important that this resident put in a vet report? If we don't know about it, we can't put in processes to help that, to fix those issues that we have and we don't know about. These are big hospitals. There's a lot of things that happen. So it's important that we know and understand it so that we can provide that high, reliable quality care for these patients. Let's say, for instance, the state ended up showing up and wanted to review that event. And we get down there and we don't know anything about it. And believe me, that happens a lot. It's better if we get down there and we're like, oh yeah, we know about this event. We reviewed this event. We debriefed on this event. We put in this entire robust investigation. We had parties from every discipline in there. We put actions into place, and these are the audits that we did, and we changed our process now because of this event. It's much easier to speak to that than it is, I didn't know anything about it. And so it's just very, very important that everybody puts in event reports. And then that's just a thank you of Sarabi, Havana, and Tiki. So I appreciate it. Thank you, guys.
Oh, come on. Something we trying to clarify some we call transgenerational myths, right? Things that get passed on year by year. cohort classes and things like that, but things like, you're attending, tells any attending? So maybe I'm not. The attending says, if I report this, I'm gonna get D. Truth or myth or fact? Truth or? Come on, folks, there's no grade on this at the end. Yep, yep, did they say it, or yep, that is true? Not true? Myth, yeah, right? And so one of the things that we want everyone to leave here is this is about the culture of safety. If you've ever been in the hospital yourself, if you ever had a child, a parent, a significant other, a loved one, you want to ensure they get the correct medication, that there's no this, there's none of that. And this is part of that. That reporting is good because reporting doesn't equal punishment. Now, what did you all hear about? I heard it about 4 or 5 times, a word. Did they talk about the person? No, they talked about the system. Okay, but there's another P word in there that they use. The processes, so that when you go back and look at it, it's about improving the processes, about how these things can be better rather than focusing on the individual, correct? That's a different process, right? If someone was negligent or something else, right? But that's a different process. So investigation and analysis, safety event, investigation analysis focuses on processes. So it's really important. And so therefore, when we see that when we get zeros, right? Hey, there's been 0 incidents. It's like, oh my gosh, we all are all stars, right? But there hasn't been one near miss, not one issue over a blank period of time. That's usually a signal that we're not appropriately reporting this. And then we go back to the culture of this fear of the what ifs, right? And the biggest what if is, I'm gonna get sued, am I gonna lose my license? Versus, oh my gosh, this happened, I have an obligation. Okay, so you all are gonna help me with this, right? You saw the reporting, right? Then you all had that in your orientations. Everyone's had that in their orientations. You hear that on your units. If you don't report, there will be a consequence. If there's an incident, right, that comes up later, then you say, wait, doctor, you were involved and you did not report it. There is a specific consequence for you. True or false? True. True. Are you saying that with confidence? Or are you saying true, kind of? Ladies, is there a consequence for not reporting?
Sure, to the patient, yeah. To the patient there is.
And so
Your patient.
that's correct. So, and why do I bring this up? Because it's like, well, if no one knows, then, what's the issue? I don't have to report it. Versus we're all saying this is a shared responsibility for each and every one of us. And even if you're part of the team and you're not the person directly who blank, there is a shared responsibility. Now, it probably goes beyond the scope of this, that if you think something needs to be reported and your attending says no, and how do you mediate, right? What do I do now? And my response would be the same way you would do with anything else. What if it had to do with mandated reporting of abuse? When someone says no and you go, wait, I think this meets my statutorily defined obligation. So the main point, one of the main messages, aside from some of the things we hear, is that we all have a responsibility to this. This is a shared responsibility, each and every one of us. And just because there isn't like an immediate, like, oh, traffic ticket, right? You're going to be cited on this, that we have a responsibility. Because we encourage the programs that if things happen and the individual didn't report, that's a discussion, right? Because it's a little bit of a part of your professionalism. Any other?
Midas, Iris, you can put them in anonymously also, so it doesn't, you can put them in, even if you have questions, you can put them in. Even if you have an issue putting in, and every charge nurse on the floor knows how to do it, or our office will come up to you and help you put it in, or if you want a safe place to put one in, you guys can always come to one of our offices over there and put it in if you want. We're open to help wherever we can. So our main thing is to try to get away from the risk segment of it and go more patient safety. So you'll hear patient safety a lot.
And so a little bit of why we're talking about it today, because we went back and looked at it and looking at the feedback we get, the things we hear, looking at the data, right? That there's months where there are zero reporting across the country. That's a standard, that there's an expectation that there will be incidents reported, period. Not the severity, not whether they result in harm, but that there is an expectation. And actually, as I said, it's the opposite. If there are, then it's an aberration, and it usually has to do with the culture and how people are seeing what they're doing.
It's much easier to put it in right away so that you still remember it, because if something happens and it comes up 3 or 4, 5 months later or a year later, it's gonna be a lot harder to remember those facts. So just putting it in real quick, it makes it a lot easier for us.
Well, I'm trying to kind of nudge folks to say, what would it take for you on when you see something to say something, right? Say, hey, like,
You guys already entered one in yourselves, like in the time you've been here, or at Joe's? Never?
Again, we're, you know, we do telework assistance, the quality department is more than happy to come up and help assist. You know, you just have questions about the system, and again, call, you know, the quality department can reach out to me and I'll get you in contact with our patient safety program. So I'd be very happy to just go over the system for you if you wanted to just know a little bit more about it. We'd be happy to do that. We are definitely here to help support.
I'm not sure about Midas, I can't speak on that, but in Iris, let's say if you don't report it anonymously, or you don't want to report it anonymously, you can always put in your email address, and it can be your work email address, it could be your home email address, it doesn't matter. But that will notify you also of when that event closes itself. So when the event closes, you'll get a notification on your email saying that this has been investigated and closed. So that'll give you guys like a reassurance that it was done.
so this is a shout out to those at St. Joseph's and the, now you're on the big screen, right? In the auditorium there. So then there's an incident, and then one of your colleagues says, oh, don't, we're so busy, that's gonna take you so much time. It's gonna slow you down, and look at all these things we have to do. What would be your hopeful response on that? You taking us off mute, Ashlyn? Or are you gonna answer that for them? This is like a shameless attempt to get you guys engaged a little bit there. We see you in the back. Remember, we see you on these huge 85-inch monitors.
Does anybody have an answer here? Mic is open.
First of all, we could not hear the question right.
So here's the question, right? What if you're working on, take your pick on any unit, and there's an event, and your colleague, your fellow resident says, oh, don't do that. That we have so much work. That's gonna really slow you down. We've got so much to do. That's like a real pain, you know, don't do it. When I'm trying to help you script it and hopefully change your thinking, your response would be?
There's an event reported.
Let's do it.
If there's an event reported, let's do it, were the responses.
Yeah, no, I heard that. I'm smiling, right? I'm just telling you that that's a real typical scenario we see it here, right? Like, oh, I've got, so this is like an extra thing. It gets viewed as a burden sometimes, right? And it gets viewed as something additional. And what we're saying that this should be inherent or part of your everyday thing and not something additional. Events will happen. So they may happen at the, maybe not the best or the most fortunate times, but they will happen. So be prepared for that. Then when it happens, it's something you got to do. It's what you do it every day in life, actually. Any questions from you all over there at St. Joe's? All right, hearing none. None, yeah. Thank you, Your Honor. No questions. How about over here? Any questions here Valley-wise? Otherwise, we're going to conclude like we started. Remember, for those of you that kind of trickled in, that you're going to hear this broad area is called, it's on your surveys, right? Not that we're asking you, but it's called Safety Event Investigation and Analysis. And that's kind of the form that we get when you all get surveyed, right? Hey, do you get an opportunity to participate in that? And the answer is yes, in each and every one of your programs. It may be called by different things, and it may not be called by that multiple polysyllabic word title, but it's called different things. So please keep that in mind. All right. On that note, we thank everybody for participating. We hope you have a great afternoon and day. Thanks.